Hi everyone, thank you for joining us. My name is Anika and I organized this with my mother. Any medical queries we have had over the past years, we have addressed to our family and friends who are doctors, the same doctors that have agreed to volunteer their time over the next 3 sessions. As mentioned in the WhatsApp messages, they will take us through various medical emergencies and the appropriate measures to be taken. This is the first of 3 sessions and will be conducted by Dr. Satish Kini, who has graciously volunteered his time to be with us today. He has over 33 years of work experience in internal medicine and has served as a frontline worker during the coronavirus pandemic in UAE and H1N1 in India. His areas of specialization are diabetes, hypertension, asthma, infectious diseases, etc. He will be taking us through how to prevent and respond to COVID, heart attacks, wheezing, and hypoglycemia. Thank you.
Okay, Anika, shall I start?
Yeah.
Okay. So, what is a heart attack? Heart attack, medically known as myocardial infarction, is a condition caused by sudden occlusion or blockage of the coronary arteries. And this cuts off the blood supply to the heart muscle, which results in dysfunction of the heart muscle, and ultimately it leads to the, if not treated adequately and in time, leads to the death of the heart muscle. And this leads to chest pain in varying manifestations. So just imagine, like, if a pipe gets suddenly blocked, the coronary arteries are nothing but pipes conveying the blood to the muscle of the heart. And if the pipe gets suddenly blocked and the blood supply gets occluded. Now, why does this happen? It has been universally proven that heart attack is caused by a sudden rupture of the plaques, or what we commonly call the blocks in the coronary arteries. Now, these blocks would have been there for a long time, maybe years or even decades. But when these blocks suddenly rupture, it initiates a series of reactions which happen immediately. It's called a multiplying cascade, which results in a massive blood clot. I mean, this is a little oversimplification, but that the gist of the issue, it blocks the artery completely. And this results in immediate what we call ischemia, or lack of blood oxygen and supply to the heart muscle. Now we must remember that the heart muscle is an extremely sensitive muscle, and it requires oxygen and glucose all the time. Because, as you know, if the heart stops beating, then it's called a cardiac arrest. So the heart can never stop beating. So it requires constant blood supply all the time. So sudden occlusion of the arteries results in 3 types of symptoms. One is the classical heart attack chest pain. This is, I would say, the type 1. A typical description is a sudden onset of severe chest pain. It's often described by the patient as sudden severe tightness or pressure, or a choking sensation in the chest, or even a more dramatic description given in some of the textbooks in medicine is that it's like an elephant sitting on your chest. I don't know if anybody can imagine an elephant sitting on your chest. That type of thing, associated with fatigue, a choking sensation, giddiness, cold sweating, breathlessness, etc. So anybody who gets out of the blue a sudden chest pain of this type, we must not assume that it is due to muscle pain or some gastric or some other things. Such a classical case in a patient who has never had this kind of pain before has to be taken to be a heart attack until proven otherwise. It may be due to other causes also. We just can't say that. The second type of presentation, which is, I would say, in my experience, most common in Asians and in women also, is the atypical chest pain. See, what I described to you initially, the typical one. Now this is atypical, where the patient may experience something like a severe heartburn, burning sensation in the chest, stomach pain or upper abdominal epigastric pain, along with some nausea, maybe even vomiting, jaw pain, back pain, pain in the limbs, commonly the left upper limb, sometimes in the right upper limb also. And this type of pain is generally not that severe as the classical type, but it is still associated with all the other, it can be associated with all the other symptoms that I described, like fatigue, choking sensation, sensation of giddiness, sweating, etc. So this second type is probably the most common presentation, and often is mistaken for, commonly in our layman's term, it's called gastric or acidity. Again, this is a very major mistake and can be differentiated only by a doctor, whether it could be gastric also. I'm not saying that it cannot be gastric, but we have to rule out a heart attack. The third type, which is most common in maybe old elderly patients and diabetics, especially diabetics who have poor control of their diabetes. They may have minimal chest pain or no chest pain at all. Now, this is called as a silent MI or a silent heart attack. So this is most common. This is an uncommon presentation, and they will, since they don't have any chest pain, they may not complain of that, but it can manifest in other ways. The patient can develop severe fatigue. They can develop severe breathlessness on exertion. They can develop what is called like sudden fainting, a loss of consciousness, what we call syncope in our medical terms. So this also has to be diagnosed only by a doctor by doing the various relevant investigations like ECG, echocardiogram, and what we say cardiac enzymes. So the degree of suspicion has to be high for this type of, but like I said, it is most common in elderly and diabetic patients. About the first aid, the famous cardiologist called Eugene Braunwald, who is still alive and is one of the most distinguished cardiologists in the world, he said, time is muscle. Now, what does this statement mean? Like I said, that cascade of events which leads to a block happens within a matter of minutes. So from the time of onset of the chest pain is the time which we count. So what is the most important priority in there's nothing much you can do at home except give a 300 mg of uncoated, and I want to stress on this point, uncoated means not the commonly used ecosprin, which is enteric coated. Uncoated aspirin like Disprin is the classic example, is to be chewed and swallowed maybe with a glass of water as soon as possible. This is about the only thing which you can do at home. Of course, make the patient comfortable. And the most important thing, I would say, in today's modern scenario, whenever the facilities are available, is to call a hospital with cardiac catheterization laboratory facilities and get the patient there as soon as possible. The sooner you get him there and the sooner he is taken to the cath lab, the better it is for the patient. The first 6 hours, not the 4, that's a mistake, 6 hours from the onset of the chest pain is called the golden period. I would say more than 6 hours is the first 3 hours. If the patient can be, in medical terms, we call it as reperfused. Reperfused means if you can open up the artery, open up the pipe and restore the blood flow to the original level, we can almost prevent the death of the heart muscle. And this is very important because once the heart muscle is completely dead, then no power on this earth can bring it back. And surprisingly, I just added this sentence: avoid physical activity or exercise, because some people, think that this may be some muscular chest pain and try to do some exercise. Like once I had a patient who was having a heart attack. He thought it's not heart attack. Maybe he did too much, and he went on to do push-ups, and then came into the hospital with a massive heart attack. So don't do all these things. Just give the patient aspirin and take him to an hospital, whichever. This I'm, of course, talking in a modern city with available facilities. In other centers, like say rural centers, the scenario may be different. But in today's world, like I'm talking about, like let's say Bangalore or any major city in India, if this happens, you have to take the patient as soon as possible to the hospital. This is the message which I wanted to convey. So avoiding heart attacks. Yeah, see, very often many patients get chest pain prior to the heart attack. Some patients, of course, get a heart attack very suddenly out of the blue without any previous warning symptoms. But in many cases, many patients get preceding symptoms called as chest pain, called as angina pectoris. That's the medical term. Now, when this happens, very, very often and very commonly in India, people neglect, thinking it may be muscle pain, it may be my gastric problem, and very often they may still go to the doctor and do an ECG. But the pitfalls of the ECG is that if it is not taken at the time of the chest pain, it may be completely normal. Or even sometimes, even in the early stages of a heart attack, it may be completely normal. Then you may ask how to diagnose. So it's a more complicated procedure just doing an ECG. We have to do what is called the cardiac enzyme estimation. We do a set of cardiac enzymes called as troponins. Okay, now these are very sensitive. So if the heart muscle is ischemic or if the heart muscle is dying, these enzymes are released into the bloodstream, and we can measure their levels. And if it's beyond certain level, it definitely indicates that you are having myocardial ischemia. So and then you should take the appropriate treatment, meaning you should go immediately and get admitted in a hospital and be evaluated by a cardiologist. And the evaluation would include mostly a emergency cardiac catheterization, which will show the degree of blockages and the thrombosis, what we call the blood clot inside the arteries. And according to that, they will act immediately. Prevention of heart attacks. This is also a very important topic in India, or rather in Asians, because subcontinental Asians are the highest risk group for heart attacks in the entire world. So control of risk factors, classical and non-classical risk factors. The classical risk factors would be most important in Indian patients. I want to stress on this, is a family history. If you have a family history of heart disease, then you are also more prone for heart disease. Very often this fact is known to the people, but they just choose to ignore it. They never do a checkup, even though their father has had a heart attack, or their mother has had a heart attack, or both have had heart attacks. Have you checked your cholesterol? No. Have you done your complete medical checkup? No. So this awareness is very important. And the three classical risk factors in Indians: diabetes, uncontrolled diabetes. Remember, diabetes is also very, very prevalent amongst Indians. They say in a population of 1.4 billion, every maybe fifth person is a diabetic in India. And out of this, at least 50% of them do not know that they're diabetic. Why? Because they simply never check properly. Many people try to do all their checkups at home by buying a glucometer. That's not possible. You can't diagnose. Glucometer is meant for home monitoring of diabetes, not for diagnosis of diabetes. Hypertension, and the very, very common problem in India. Every third Indian is a hypertensive patient. Third or fourth Indian. That's also a major risk factor and needs to be treated aggressively from a young age. Lipids. Lipids means your, in simple terms, cholesterol. Now, Indians have a peculiar type of lipid profile which I've been seeing over the years. Most of the time, we never have very high cholesterol or very high lipids. It's just that one pattern which you see where the HDL cholesterol, which is called the good cholesterol, which should be high, this protects us from heart disease, is low. Now, this HDL cholesterol being low itself is an independent risk factor for development of heart disease. Many people ignore this, or even doctors don't advise the patients properly. So most Indian patients have low HDL, moderately elevated LDL cholesterol, and the high what we call triglycerides. These are what we call the free fatty acids combined together to form what is called triglycerides. Now, this, if pattern is there and if there's a family history, all these three conditions, these classical risk factors, diabetes, hypertension, and lipids, need to be controlled. All the three of them. If a patient has all three need to be controlled very well. You can't just control your diabetes and hypertension and say, I won't take cholesterol tablet. And of course, smoking has been proved beyond doubt to be the number one risk factor for development of heart disease. So stopping smoking at an early age is a very important thing. So this sort of sums up this heart attack thing. Of course, it's a very, very big topic, but I hope I have covered the main areas for as far as this discussion is concerned.
Given the importance of time during heart attacks, would it be advisable to wait for an ambulance or just take the patient in the car? And if car, should the patient be sitting or lying down?
That depends on the circumstances, I suppose. If you can get an ambulance to come, see, nowadays most hospitals have ambulances in various areas, which are always ready for the patients, especially in the the bigger cities. So I think, but if you're not getting an ambulance due to any reason, it is always better to take the patient by car to the nearest hospital. Okay, the patient can be sitting or lying down, whichever is comfortable for him. That depends. You see, like if, for example, if he has a low blood pressure, if he's feeling giddy, it's always better that the patient is lying down with his legs up.
Please tell me.
With the legs up. But if he is comfortable in the sitting position, not feeling giddy, then he can be sitting.
If I may add to this question, Satish, can I? Yeah, I just like to give a real life incident that happened. A friend of mine, a very fit fellow who used to jog and all that, suddenly developed chest pain. He went to a local hospital. It was diagnosed as a heart attack. And they had to shift him to a bigger hospital. They called the ambulance from that hospital to pick him up. And the ambulance was sent with a doctor and a nurse with oxygen. And on the way to the major hospital, this person had a cardiac arrest. Because the doctor was there in the ambulance, he could continue giving what is called CPR. He reached the hospital completely unconscious, but the doctor was giving him cardiopulmonary resuscitation. They continued CPR for almost 45 minutes before his heart started beating again. They did an emergency angioplasty on him, and he's fine today. He's absolutely fine. He goes on, he even travels abroad. So the presence of that doctor in that ambulance made the difference. So, like, If possible, go in an ambulance. But if it's going to take a long time, then go in your own vehicle.
Yeah. Most important you have to think is, if the ambulance for any reason is going to take time or it's not available, then do not delay. Definitely, ambulance is better in any time, like Naveen said, because many patients can be saved because of CPR. And I also think that all our citizens, at least, and the important learning which we could do is what is called enroll in the basic life sciences course. No, it's called BLS. See, we physicians, we have to do, especially when I was working in UAE, we had to do both BLS and what is called ACLS, that is Advanced Cardiac Life Sciences. This shows us what to do if a patient has a cardiac arrest. This is training about what to do if a patient has a cardiac arrest at home. Because see, once a patient has a cardiac arrest, we have only 4 minutes. If the blood supply to the brain is not restored within 4 minutes, then the patient is gone. So by doing cardiopulmonary resuscitation, we can restore at least the blood supply partially to the brain and the heart, which are the two vital organs. And very often, if it is continued till the patient reaches the hospital, then many lives can be saved.
The next question we have is, why chew and swallow aspirin? Can it be dissolved in water and consumed?
Yeah. It's the same thing. You can either chew or you can dissolve it in water. See, by chewing the aspirin, you are already breaking it up. Then you just drink it with a glass of water. Instead of dissolving it in a glass of water, and that takes about 2 or 3 minutes. You can do that also. But again, like I said, the sooner aspirin is very quickly absorbed from the system. Okay. So chewable aspirin is the important point, not enteric coated. Enteric coated aspirins do not work in the acute situation. Okay, because enteric coated it is coated with some substances to prevent the release into the stomach. It is slowly released in the intestine, absorbed from the intestine. So that should not be the case. It should be uncoated aspirin for a quick, immediate effect.
Few names of brands of 300 mg coated aspirin.
Uncoated aspirin.
Yes.
Disprin, Colsprin, simple Disprin is available. I think there are some certain child pediatric formulations also, but they're not 300 mg, they are much lower, 75, 82 mg and all. Baby aspirin, it's called. I'm not sure about that. But the commonest brand is Disprin.
The next question is, what is the use of sorbitrate tablet?
Yeah, okay, that's a good question. I'm glad somebody asked that. See, sorbitrate is a sort of what we call a nitrate, which dilates the coronary arteries. Before, we also used to use it almost for every patient who used to come with chest pain. But see, there are various types of heart attacks. And if the patient has what is called an inferior wall MI, meaning it affects the right side of the heart in the base of the heart, they can often develop what is called as right ventricular failure or low, and resulting in low blood pressure. So in this situation, if we give sorbitrate, the patient can collapse because of very low blood pressure. So if we are sure that it is not an inferior wall MI or a inferior wall heart attack, then certainly we can give sorbitrate. But how can we be sure of that at home? Okay, so like in cases of what we call anterior wall or MI heart attack, then certainly we can give sorbitrate. But unless you do an ECG at that time, and that is read by somebody who knows how to read an ECG, you can't make out which is what. So that is why sorbitrate is not routinely recommended as a treatment. There are other things also. There are things like some people say if the heart rate is high, you can give him a beta blocker, to reduce the heart rate. But all those things may or may not work, and they are not, strong recommendations anymore. But aspirin is definitely a universal recommendation. Sorbitrate, we have to be careful because inferior valve patients can just collapse and sometimes even die just because their blood pressure reaches zero if you give sorbitrate.
If I can add a thing here, I think one of the things what we can do is to calm down the patient. Tell him that he's going to be okay.
Yeah.
Talk to him about some pleasant memories which he has of the past so that he calms down, and that itself will bring down his heart rate, bring down his stress levels, and improve the outcome in people who are having heart attacks. It is important that the bystanders do not panic. If you panic, he panics more.
And also, it is also better to be prepared, instead of running around searching for an hospital. Always, be aware of which hospital is closest to your house. Do they have all these cardiac care, acute cardiac care facilities? What are the numbers, phone numbers, which we have to contact? Suppose we keep all these things ready, then we don't have to panic and go around searching for these numbers in a hurry. The next topic is named as wheezing. Wheezing is not a disease at all, even though it's thought to be. Wheezing is only a symptom, generally a symptom of acute asthma, where you get a sort of, when a patient breathes, especially when he breathes out, you get a whistling sort of sound, which is audible to others. That is called as wheezing. It's not a disease. Commonly, it's a symptom of asthma, but it can be there in a host of other diseases as well. There are many diseases of the lung and sometimes even of the upper airway, which can cause what looks like wheezing or breathlessness. And all of these are not the same. But if we are talking about asthma is a condition where acute bronchospasm, or meaning narrowing of the airways, happens, triggered by various triggering factors like allergies, viral or bacterial infections, irritant chemicals, dust, smoke, and there are many common household allergens also. All these things, maybe singly or maybe in combination, can trigger what is called as acute narrowing of the airways. That is called as acute bronchospasm. Now, this is also a complicated process, which is caused mainly by an immune reaction. That is, reaction between all these antigens. Antigens, like I mentioned, allergens which are present all over in the air and in the house, dust, smoke, cigarette smoke, and viral and bacterial infections. The end result is the airways react and become narrow. So the space for the air to pass through becomes less. Also, there are many other reactions happening, including increased mucus production and thickening of the airways. That is in the longer term, if you leave it for a longer time. The most important treatment of acute asthma, if it is severe, the patient has to go immediately to the hospital and has to be assessed by a doctor and get the emergency treatment, which may include nebulizations. And sometimes, to determine the severity of the asthma and whether it requires hospitalization, we do what is called as an arterial blood gas analysis, where we take a sample of blood from your artery, not from the vein, in the wrist. So that gives us an idea, and especially if certain parameters are high, then such patients need to be admitted to the hospital. We also usually give either IV or oral corticosteroids for this condition because they are life-saving in asthma. But this is all in the acute treatment. You can take, if the asthma attack is mild, you can take nebulizations at home or even inhalers at home through a spacer device. And in a chronic case, meaning when it's not an acute emergency, but patient is getting recurrent wheezing, the most important test I would say is a pulmonary function test, which is often not done by anybody, including many doctors. They just go on treating it as asthma, which I feel is very wrong. You have to make a proper, establish a proper disease pattern or proper diagnosis of asthma, because there are many other lung diseases which can look like asthma, but are actually not. For example, there's another common disease called as COPD, or meaning chronic obstructive pulmonary disease. This is mainly seen in people who are heavy smokers. Now, they also will get wheezing, they also will get breathlessness, but the entire pathology or the positive factors in that patient is totally different, because there is destruction of the lungs. Remember, asthma is only a disease of the airways, but other lung diseases are there. There are diseases like what we call lung fibrosis, which are all different and require different treatment. And this can be differentiated by doing this pulmonary function test. Along with that, we do many times blood tests, X-rays, in some cases CT scans. Like for example, for diagnosis of lung fibrosis, CT scans are very useful. And sometimes even, if there are lesions in the lung, they may do a biopsy of the lungs and all that. Now, that's all beyond the scope of this discussion. But what is the message I want to convey to all the asthmatic patients in India? This last sentence, regular use of combination inhalers is the most important thing to prevent asthma attacks. Now, this may sound very simple. We advise each and every patient that they have to take their inhalers very, very regularly, without fail, twice a day. And of course, in many cases, once the patient gets relief from symptoms, we step it down. It's called step down in treatment, where we reduce it to the lowest possible dose. But the emphasis is it should not be stopped in between. Now, does this happen? Unfortunately, no. I would say in at least 80 to 90% of a patient, in spite of doctor's advice, in spite of being intelligent and knowledgeable people, most people stop the inhalers in between. Now I'm feeling all right. Why should I take the inhaler? Or simple, you just forget, or simple carelessness. Now, this should not happen. If you are a proven asthmatic and you have been proven by pulmonary function test to have asthma, and you want to get rid of the problem completely, you have to take the inhaler, a maintenance dose of the inhaler. And by inhaler, I don't mean this common one which you can see here, that's called the Asthalin or Ventolin. That's just salbutamol. That medicine doesn't do anything. You have to take preventive inhalers, not reliever inhalers, preventive inhalers which contain inhaled steroids. And nowadays, combination of both these long-acting bronchodilators and the steroids have been proven to be very, very efficacious in preventing attacks. If not completely cure the asthma, at least it prevents you from getting severe attacks and getting hospitalized. But for it to be effective, the treatment has to be continuous. So my message is, please, if you are an asthmatic, unless of course maybe there are some very mild asthmatic patients who may get attacks like once a year or something like that. Such patients may be okay. But they also have to have the pulmonary function test. But anyone getting regular asthma attacks, like say more than a few times a year, has to take these inhalers if he wants to be healthy in his old age. Because if you don't do that, your lungs, the lung airways can develop fibrosis in the long term. So to prevent this, the inhalers are very important. This is my message for asthma.
Questions are about asthma and wheezing.
Yes.
Is there an age limit for PFT? Can younger children with asthma do PFT?
Yes, yes, anybody can do PFT as long as they're able to blow into that machine. Okay, maybe very young children, I don't know, Naveen can answer that.
About the age of 6 is generally what we do. Because otherwise they don't have that much lung power to actually blow and get a meaningful result.
Yeah, yeah. There are various patterns of the spirometry. See, there are basically two types of patterns. To get technical, it's called obstructive pattern and restrictive pattern. Some diseases like asthma or COPD, they have mainly obstructive pattern. And other diseases, like I told, like lung fibrosis or interstitial pneumonia, various other things, would show a restrictive pattern. So that gives us a clue as to what disease the patient has got. That's why it's very important. All that wheezes is not asthma. There's a famous saying. Okay, all that wheezes is not asthma. This is very important to understand. Just because you are wheezing, you go straight away and start him on some inhaler and steroid, it's wrong. It has to be diagnosed properly, and the gold standard for diagnosis is spirometry.
The next question is an air purifier worth buying?
Yes, I think so. What extent it will help depends on probably the size of your house. Even now, the modern air conditioners themselves, most of the air conditioners come with filters, which filter out most of the dust and bacteria and viruses and all those things. So, more than the air purifier, air conditioner itself will help. I think.
Dyson has come out with a very good air purifier. Suppose it has very good reviews. So it's a little expensive, but it is worth
Dyson
trying.
has come out with a very good vacuum cleaner also, no?
Yeah.
Which supposed to reduce the particulate matter in the house.
The last question for asthma and wheezing is, does swimming help in curing asthma since the sport involves a lot of breathing?
Yeah, definitely. Any form of exercise is good for asthmatics and improving their lung function. But having said that, there is a specific type of asthma called as exercise-induced asthma, especially common in children and adolescents. Okay, exercise-induced asthma, and that has to be, if the patient has that, you can prove it by doing certain tests. If the patient has a history of getting wheezing during the time of exercise, then we have to give him the preventive treatments before he exercises. But swimming is certainly a good exercise, right?
Let me stress here that there is no cure for asthma. It is just control. If at all you outgrow asthma, but there is no medicine which just cures it. Like many people sell it, especially in the other forms of medicine, saying I can cure your asthma. There is no cure.
It's the best possible treatment for asthma in today's world. And this I'm saying with 33 years of experience of using, and all of us use, is regular usage of the inhalers. Okay, that is the best inhaler to use is a combination inhaler. Combination of steroid and what are called as LABAs. LABAs means long-acting bronchodilator. Okay. So this combination has been found to be very effective in preventing what is called the acute inflammation inside your airways and stopping that allergic immune reaction, which helps your body to forget about the disease itself. Okay, but it has to be continuous. It has to be continuous. Shall I move on to the next topic?
Can I ask a question?
Yes, please.
My grandson from childhood has had asthma, and he was taking inhalers, etc. Now he's 16.
Yes.
Only in the last 2 years, it seems to have stopped. The attacks seem to have stopped. My question is, will this recur in his later on in his life?
That's always a possibility, but we have to wait and see. I think my brother, Dr. Kini, will be able to answer that question better. But as far as I know, that's a very common problem. Many children have asthma during childhood, and somehow when they grow up, maybe due to hormonal changes or whatever, the asthma disappears. But what we have to do is keep a close watch. And if he develops any symptoms again, like cough and wheezing, then the best thing is to do the pulmonary function test and start him on treatment.
Correct. Yeah, he was on long-term inhalers. And it's, as you say, it's very easy to not take it. It's especially children. So it's the parents' job.
No, adults also. Children are better than adults.
Yeah. So anyway, so far, right now, that seems to have, disappeared. But
so we can just observe and watch. If at all you have a doubt whether he still has asthma, then just take him to some pulmonologist or even some laboratory and get a pulmonary function test done. If the pulmonary function tests are completely normal, then there's no need for any treatment.
Oh, okay. Okay. That's good.
If I can add, hello, ma'am. I'm his brother. I'm Naveen.
Yeah.
If I can add a few things, like you said, most children outgrow their asthma, but that tendency to wheeze will always be there. They may have occasional attacks once a year or something, and that can usually be managed without regular daily inhalers.
Right.
Some of them don't get attacks at all, but like Satish said, you need to keep a close watch and if necessary, investigate.
Okay. Okay. Thank you.
Thank you.
Okay. Anybody else? Any other questions? Or I'll move on to the next topic.
Hello.
Yes.
Yeah, I'm Praveen here, sir.
Yeah, tell me.
No, in fact, my son was having asthma, wheezing, but he has been served with the steroid. But is there any continuation of addiction over there after that? Now he is okay.
He has been diagnosed by
Wheezing only, not asthma, wheezing in the earlier stage.
No, but like I said, have you done at that time? Have you done a pulmonary function testing for him?
No, yeah, we have done everything, and it has been now ruled out. But he has been admitted with the steroid at that time. Now he is around 23 years. Now he is not having anything.
Yeah, like I said, if many children outgrow their asthma, if he is not having any symptoms, but see, sometimes they can develop. They will have that tendency towards asthma throughout their life.
Okay.
So if they develop any symptoms, just take him to a doctor and get this test done. Okay. The most blood test, chest X-ray, and all don't help much in the diagnosis. Okay. We do those tests only to rule out any other conditions. Okay. Pulmonary function testing is the most at the time of pulmonary function testing. If you do when the patient is completely normal, it may be normal.
Okay.
You have to do it. If he develops any symptoms like cough and difficulty in breathing or wheezing, then you take him to a pulmonologist and get it tested. And then you may have to take, depending on the result, you may have to take the steroid inhalers again. I want to emphasize again and again that steroid inhalers are perfectly safe.
Okay.
Many people have this concept about, oh, it's a steroid, it should not be given. That's not true. It's been proved beyond doubt. And we have been using this for the last more than 30 years now, that steroid inhalers are very safe because it's a specially formulated steroid formulation where it acts only locally in the lung and doesn't get absorbed into the bloodstream. Very little gets absorbed into the bloodstream. So it's a beautiful treatment for a condition, what we call a target specific treatment, which we cannot offer for any other disease.
Okay.
Okay.
Right.
It is not that your child is addicted to the steroids. It is just that the disease requires a daily dose of steroid to keep it under control. If you stop it, the disease comes back. That's it. That is the only.
Hello, doctor. I have a question.
Thank you.
Yes.
What are lifestyle changes required for people with bronchial issues?
Well, the most important thing, if there is avoiding smoking and exposure to irritant chemicals that in certain cases, I mean, depends on their profession and things like that. That's easier said than done. Like for example, if a person is a carpenter or a painter, they will definitely be exposed to more amounts of irritant, and even people, one common cause. Recently, I was talking to a pulmonologist. Are household birds, especially pigeons. A lot of people feed pigeons, but pigeon feathers and pigeon droppings are highly allergenic. So if you have any wheezing tendency or asthmatic tendency, it's definitely better to stay away from pigeons. Then, of course, maintaining good physical exercise, improving your lung function, doing yoga and pranayama exercises which improve your lung function. These are all good for asthma.
If I may add a few things, especially if you're talking about children, few things you can do is avoid stuffed toys in your house. Vacuum clean your house, especially the sofa and the carpets regularly, because house dust mite is one of the major triggers. If you have cockroaches in your house, cockroach droppings are another major allergen which causing asthma in children. Avoid perfumes, agarbattis, etc. in the house. A lot of children have an emotional component to asthma. So the moment the child is under stress, the wheezing increases. So you help them to control their stress by yoga, meditation, etc. These are a few things which you can do in your house if you have a child having asthma.
So these same allergens also cause rashes on skin. The allergens that cause.
It can cause, yeah. It's the same spectrum of diseases called atopic dermatitis. Atopic dermatitis, allergy in the nose, that is allergic rhinitis, and asthma all go together. And all three can exist in one person, and it can have various degrees of severity.
It's important to look for all the sources of the allergens. And like you said, house dust mite is a very, very common problem. And that can never be completely eliminated, but you can reduce the concentration of house dust mite by regular vacuuming with a good vacuum cleaner, and also keeping your pillows and mattresses in the sunlight for some time.
I did notice that stress, like for my grandson, if the father left on a business trip, we could be rest assured he would get an asthma attack. He did not like that. And I just want to add, for those who are adults suffering from asthma, never visit a bird sanctuary. I lost a dear friend because she didn't have her inhaler. She went to a bird sanctuary in Singapore, and before she could reach the hospital, it was over. So just to keep these things in mind,
I see a lot of children coming to me just before the exams.
Yeah.
The exam is one of the major stresses.
Somehow they seem to be anxious, these children who suffer from asthma. It's kind of a double thing. They're anxious, so they get asthma. They get asthma, they're anxious. Yeah.
Yeah, that's why it's important to at least continue the steroid inhalers every day, so that at least that allergic component of the asthma is controlled.
Correct.
The emotional component may require other things rather than medicines itself. But the allergic component, if it can be controlled, the inflammation inside the lung airways, it can be controlled by taking regular steroid inhalers. Okay. So I'll move on to the next topic now. That is hypoglycemia. Is that okay?
Yeah.
Yeah, hypoglycemia, we'll cover this briefly. It's the sudden reduction of blood sugar below 60 milligrams, causing symptoms to the patient due to various reasons. Usually seen in diabetic patients, but it can happen to normal patients also. Usually caused by skipping meals, long interval between meals, excessive fasting, and most commonly in diabetic patients, especially overdosage of medications. Or it's not just an overdosage; it may be just a inappropriate or poorly adjusted dose of medication, because each diabetic patient is also different. It's not like everybody gets a blanket dose of the same insulin. Some patients require different type of insulin. Some patients require long-term, long-acting insulin. Some patients require short-acting insulin. Some patients require pre-mixed insulins, or even the oral hypoglycemics, meaning the oral drugs which we use for diabetes. Those are all, some of these drugs are very powerful, especially, this may be surprising for many people, the cheaper medications. Like everybody must be knowing about the diabetic medication called Dionil. Dionil contains sulfonyl urea drug called as glibenclamide. Now this glibenclamide is the longest acting of all the drugs available for diabetes. It has a half-life of over 35 to 36 hours. That means more than almost 1.5 days. But it is the cheapest tablet available. So many people take this. But it is the cheaper tablets are the most powerful tablets sometimes, and they can cause severe hypoglycemia in patients. In fact, and now see, many patients have this misconception that if a tablet is costly, it is very strong. That's not true. It's absolutely not true. In fact, we have now the latest tablets. We have a group of drugs called the gliptins, and they have the very latest group of drugs are called the SGLT2 inhibitors. They are very expensive but very good. And in them, the risk of low blood sugar due to the mechanism of action, their mechanism of action is very, very low. Okay. So hypoglycemia can happen in both patients who are taking oral drugs and insulin, or a combination of both. So what symptoms do we see? It depends on the level of the blood sugar. If it's just mild to moderate, let's say a blood sugar of 50 or 50 or 60, the common symptoms are patient feels weak, sudden weakness, sudden hunger, sweating, sensation of giddiness. And sometimes, in some patients, it's common to have some altered behavior. It may take in various forms. They may suddenly become more agitated, violent, or starts simply screaming or shouting, things like that. But these are patients who are still conscious. And what is the treatment in them? Immediately give them some sweet beverage, snack, glucose powder, fruits. If it is a mild attack, you can even give them some snack to eat. That, of course, may take more time. But if you want immediate action, the best thing is some sweet drink or a chocolate, or the best is glucose powder, like Glucon-D and all that. You can just even put it in the mouth. But what to do if the patient becomes unconscious? Now, this is a very important question. And unconscious patients usually have severe hypoglycemia, where the sugars may be as low as 10 or 20 milligrams. And usually, by the time they're discovered, and one more thing in these unconscious patients, I want to stress, it is dangerous to force feed an unconscious patient. Why? Because when you're pouring some water or drinks or anything into their mouth, they may choke. It may go the wrong way and it may go into the lungs. So force feeding unconscious patients is not the thing to be done. Ideally, you should immediately take them to the hospital, and the patient should be given IV glucose or IV dextrose. But that again may be difficult due to various reasons in certain cases. So there's one beautiful treatment available which can be done at home. It's called glucagon. Now this glucagon is a counteractory hormone to insulin. It's also produced by the pancreas, but it counteracts the effects of hypoglycemia by raising the blood sugar. Now this is available in that EpiPen form. The common, it's a pre-filled syringe with ready-made for injection with a ready-made needle. It costs about 1,000 rupees, I think. But every diabetic patient, I think, should have this EpiPen of glucagon in their house, especially if he's had, especially like if he's alone or elderly and unable to take care of themselves. So this EpiPen is meant for emergencies, where you just remove the needle and just inject it into the muscle, say the thigh or something, which is quite safe. And that has an immediate effect of raising the blood sugar. At least this buys time till the patient can reach the hospital. So glucagon is an important thing for patients who are, especially who are prone for hypoglycemia, who are taking large doses of insulin or oral medications, and patients who have renal dysfunction, meaning if their kidneys are affected because of diabetes and their creatinine is high. Such patients also are very prone for hypoglycemia because the metabolism of all the drugs which they are taking gets prolonged. So in such patients, very important to have this glucagon EpiPen in the house. And it can be administered by virtually anybody. Just like, you just remove the cap and just inject it into I think in many pens it gets injected automatically. One should just put it into the muscle. Another thing which can be done is you can just take a little glucose powder and rub it on the lips and on the tongue, hoping that some amount of glucose can be absorbed from what we call, but do not make it into a solution and make the patient drink if he is unconscious, because that can lead to more complications later, especially if the glucose enters the lung. Then they can get what is called as aspiration pneumonia. So these are the things to be done for hypoglycemia. Best way, of course, is to be in regular touch with your physician or diabetologist and adjust your dosage of your medications. Because like I said, each patient is different, and the treatment of diabetes is a continuous process. It's not easy. Most patients can be treated with some regimen which suits them, but that often requires a lot of trial and error. That's why generally in most patients we start the treatment with lower doses, and then depending on the response, we gradually go on increasing.
The next questions are about hypoglycemia.
Yes.
What do you consider a high dosage of insulin?
Well, I can't really see. Each patient is different, and the requirements of each patient are different. See, most patients we are able to control them with mild to moderate dosage of insulin, say anything from about 16 to maybe up to 60 or even 100 units of insulin. But there are many patients who are what we call insulin resistant, and they certainly require higher doses of insulin. Okay, so, and now we have an invention also called the insulin pump, which is a sort of pump device which injects insulin into your bloodstream all the time, continuously. So for patients who require high doses of insulin, instead of taking multiple injections throughout the day, you will probably be served better by an insulin pump, which is a specialty by itself.
The last question we have here is how to differentiate between symptoms of low blood sugar and high blood sugar, since many of the symptoms are similar, like giddiness, etc.
No, they are not similar. I don't think so. See, mainly when a patient has high blood sugars, most Indian patients have very little symptoms when they have high blood sugars. Your sugar may be 400 or 500, but they don't have any symptoms. What? Giddiness, weakness, fatigue, maybe. But the important differentiating point is when you get low blood sugar, you get it suddenly. It happens suddenly. If it's a sudden onset of weakness, fatigue, hunger, sweating, giddiness, or even a loss, altered behavior, or a loss of consciousness, that is most likely to. I have seen hypoglycemia in all sorts of forms. Okay. I've seen patients come screaming into the hospital, screaming at the top of the voice, talking incoherently, and when you check the blood sugar, it is 10 or 20. That's called a neurohypoglycemia, where it predominantly affects the brain. Some patients can just fall unconscious. So any unconscious patient, whenever an unconscious patient is brought to the hospital, any hospital, the first thing we do is check the blood sugar. First thing, rule that out.
The situation described in this question can occur in children, especially newly diagnosed juvenile diabetics. They can go into a condition called diabetic ketoacidosis because of very high sugars. And there, yes, but like Dr. Satish said, the level of consciousness will help you differentiate. They will not, when the sugar is low, they tend to become less and less conscious, whereas if the sugar is very high, they have a difficulty in breathing. It's called an acidotic breathing. That is one of the ways probably you can differentiate between very high and very low sugars.